Hello everyone, I'm Mike Conway. I'm a Senior Lecturer in Digital Health at the University of Melbourne School of Computing and Information Systems, and also the Centre for Digital Transformation of Health, again at the University of Melbourne. Today I'll be talking about digital health and medical AI in Australia generally, and more specifically here at the University of Melbourne. So I haven't been at the University of Melbourne for that long. Prior to taking up my current position here in Australia in 2021, I worked in the United States, latterly at the University of Utah for several years. So I've been spending the last 3 years that I've been in Australia learning about the digital health and medical AI environment in Australia, and that's what I'm going to be talking about today. Okay, so I'll be talking about two broad topics today. First of all, digital health and medical AI, specifically in Australia, and then I'll briefly present some of the major research centres for digital health research in Australia, talk a little bit about some of the key stakeholders, and also say a little bit about how medical AI has progressed in Australia compared to other places, like, for example, the United States. I'll also talk a little about two specific medical AI-related projects at the University of Melbourne. First, the Validitron, which is a software and physical environment set up to support the development of digital health and medical AI technologies. And second, I'll say a little bit about a project that involved developing clinical natural language processing algorithms to identify suicidal ideation and self-harm from clinical notes. But first of all, I should say something about the particular context we're working in Australia. So as I mentioned, I'm relatively new to the country. I've been here since 2021. But I've been around long enough to notice some key distinctive features about Australia. First of all, there are some geographical realities, geographical facts that inform some aspects of the Australian health system. So, for example, if you think about Japan, for instance, and I understand that Japan has a population of about 125 million. And a population density of about 336 people per square kilometre. Also, if we think about India, say, as discussed by our previous speaker, Dr. Patil. So India has a population of about, I understand, about 1.4 billion people, and it's the largest country by population in the world. I understand it overtook China last year in terms of its population size. And India has a population density of 485 people per square kilometre. So Australia is quite different in that there's a lot of land here, but relatively speaking, not that many people. So we have a population density of only 3 people per square kilometre. And in Australia, most of the population lives on the coast, particularly the east coast of the country. But there's a significant population of individuals who live in very, very remote locations. And given all this, there's been a strong emphasis on telehealth in Australia to cater for this rural population. Another feature specific to Australia is a diverse population, with 30% of Australians born outside of Australia, and 50% of Australians having at least one parent who was born overseas. And this leads to considerable cultural and linguistic diversity in the country. And despite these different contexts, there are issues that we all have in common. Okay, like, for example, rising healthcare costs and an ageing population. And these type of problems, wherever we're located, they will benefit from a digital health or medical AI response. Okay. So Australia has invested substantially in digital health and medical AI in the last few years, with a new government agency set up, the digitalhealth.gov.au agency, and also a professional organisation called the Australasian Institute of Digital Health. And in addition to that, there are multiple research centres that have been set up in Australia over the last few years. And these include, and this is not a comprehensive list, it's just a selection, but these include the Centre for Health Informatics at Macquarie University in Sydney, the Australian eHealth Research Centre, which is part of CSIRO, sometimes pronounced CSIRO, which is the Commonwealth Scientific and Industrial Research Organisation, and that's a federal research organisation here in Australia. There's also the Digital Health and Informatics Network at the University of Sydney, the Queensland Digital Health Centre at the University of Queensland, and at my own institution, the Centre for Digital Transformation of Health at the University of Melbourne. And in Melbourne, there is quite a lot of digital health activity here. For instance, at the Digital Health Hub at the Royal Melbourne Institute of Technology. Monash University, also in Melbourne, although not listed here, does an awful lot of digital health work. And also widening out to AI and machine learning more generally, the Australian Institute for Machine Learning is located at the University of Adelaide, and that's quite a big national effort to advance machine learning research. Okay, so that just gives you an idea of some of the research activity here that's going on in Australia generally. Okay, in terms of stakeholders, and I imagine this would be fairly similar in Japan. We have a number of stakeholders. Involved in integrating medical AI and digital health innovations into the health system and ultimately improving health outcomes for people. So first of all, we have universities on the left there. So going left to right, we have universities funded by governments and private sector and foundations, which produce medical AI research. Then we have the commercial sector. So we have startups, we have established companies in this area. We have Medicare, which is a government health insurance system here in Australia. So all citizens and permanent residents are enrolled in Medicare. We also have a robust private health insurance industry here, and various different professional organisations like the Australian Medical Association or the Australasian College of Nursing. We have the federal government here in Australia. As you know, Australia is a federally organised country, so we have the federal government, and we have quite powerful state governments as well in New South Wales, Victoria, Queensland, Western Australia, South Australia, Tasmania. And we also have a substantial amount of government research as well, direct government research, run by CSIRO and a few other entities too. So that's a rough picture of the stakeholders involved in the institutional stakeholders involved in medical AI and digital health in Australia. Of course, there's the patient, there's the consumer as well, but I focused on the institutional stakeholders here. Okay. So despite there being a lot of interest in the development of specifically medical AI in the clinical environment here in Australia, very little has actually been implemented so far. And there are many reasons presented for why medical AI hasn't developed as much as we might have hoped for in the Australian context. And there are a bunch of possible reasons for this. It could be that there's a lack of clinician trust in unexplained models. So we have black box models, and physicians and clinicians generally don't trust the results of black box models. Okay, so that's one explanation. Another explanation relates to data privacy concerns from consumers. So consumers worried about their data being used in the context of digital health and algorithms. There are some concerns about health inequity due to underlying data biases and underdeveloped or absent government regulation. That's another concern that people have, along with liability risks on the part of hospitals and health systems. But this is true in many countries. So why is Australia lagging in this situation? Because all these issues relate to all countries, but the question for us here, I guess, is why is Australia lagging a little bit behind in the execution of medical AI? Well, this paper I reference at the bottom of the screen, the why clinical artificial intelligence is almost non-existent in Australian hospitals and how to fix it. That does suggest some solutions and some reasons why medical AI hasn't advanced quite as much as we might have hoped. But I'm just picking out three particular reasons here why that I think are contributing to why we're a little bit behind where we probably want to be here in Australia. So Australia is relatively small by population. It has a relatively small tech sector. We don't have homegrown tech companies on the scale of Google that cater specifically for the Australian market, and we don't have the same tech startup culture in Australia. Which is not to say that we don't have tech startups. We do have tech startups, and we do have companies, in this area, but it's just probably not quite as well developed as you would find in somewhere like, for example, California. The regulatory environment is also an important factor here in Australia. So Australia's laws regarding de-identification of clinical data for research purposes are a little bit vague. So if you compare the laws in Australia to the laws in the United States, so the US has the HIPAA Act, so the Health Insurance Portability and Accountability Act, which is a privacy act that stipulates that if 18 identified data types, so things like telephone numbers, addresses, birth dates, and so on, if they're removed from data, then that data is at least in principle shareable. So there's a procedure for what you need to do to get data into a condition where you can share it. That doesn't exist to the same extent in Australia, where the rules regarding what is adequate de-identification are a little bit vaguer. And that, of course, discourages data sharing because it starts to be perceived as a risky endeavour. Okay. Also, and this isn't universally true, but it's certainly true in Victoria, where the University of Melbourne is located, the state of Victoria. Hospital-based electronic health records are not as well established in Australia as they are in the US, with some notable exceptions. Although we do have, here in Victoria, in Melbourne, we do have a pretty long tradition now of GP electronic health records, so primary care electronic health record systems. I think it's fair to say that electronic health record systems aren't quite as well established in hospitals compared to say the United States. Okay. So, well, I guess the conclusion of this slide is that there's still a lot of work to do. We still have plenty to do here in Australia, in Victoria, and in Melbourne. Okay, so I'm going to talk about two specific examples of projects. I ought to say that I'm not directly involved in either of these projects. They're not my projects, but they are interesting local initiatives at the University of Melbourne, and they are associated with the Centre for Digital Transformation of Health, which I'm affiliated with. So my first example is the Validatron. So this research project is an attempt to address the difficult transition from development of medical AI to implementation of medical AI. Okay. So many of the challenges associated with implementing medical AI and digital health technologies more generally aren't really primarily technical. So implementing medical AI that's helpful in the medical context is really difficult. So you might have an algorithm that works very well when you've tested it locally and done, your cross-validation, you've rebalanced your data set and you used a fancy new deep learning algorithm, and it all works very well. But when you try and execute that in the clinic, things don't go quite as well. And that's an endemic problem in medical and clinical AI. So one well-known example of a system that didn't quite work out as well as we might have hoped was the Watson health system. So Watson had considerable public success winning a general knowledge US game show in about 2011, but efforts to translate that core technology to the health system were not really straightforward. And there are lots of reasons for this, but part of the problem related to underestimating the difficulty of integrating medical AI with existing clinical workflows, which is of course more of a socio-technical issue than it is a technical issue per se. So how do we implement medical AI and other types of digital health interventions? Well, this isn't just an AI issue. It's not just a machine learning issue. It really requires human-computer interaction research and implementation science. So if you look at the left-hand side of the screen here, this slide uses the example of drug development. So if you think of the drug development process, we have a very well-defined process of discovering and developing drugs. We do initial development, we do preclinical research and safety assessment, followed by clinical research and trials and regulatory review and so on. And we also have a system of post-market safety monitoring. And this framework doesn't exist for medical AI and digital health interventions in anything like the same way. So the Validitron at the University of Melbourne is an attempt to address this problem and fill the big empty gap that you see on this slide. And the idea is it allows for rigorous testing of digital health products. Okay. And the Validitron has multiple components, but the two key components are the digital sandbox, which provides electronic health record systems for primary care, and also electronic health systems for record systems for hospitals. And it has a telehealth client as well, with which researchers and developers can experiment. Also, and this is really crucial, there's a physical space, including a consultation room, a hospital bed, and associated systems, in which researchers and developers can test medical AI systems in a realistic setting. So they can test workflows of systems in a way that is difficult to do otherwise. Okay, so I'll just show you this brief video.
When you come up with a digital health app or you develop a new innovation, it's really unclear about how to get it implemented into the healthcare system. Hospitals and clinics want to be innovative, but it's a very risky place to try new innovations.
We see increasing numbers of people in the community with devices that they're carrying in their everyday lives who are also interested in doing things to support their health.
And so there's this big gap between all the knowledge that's being produced and how do we bring that knowledge and those advancements into healthcare.
It's not a technical issue. It's about figuring out how to create a new model of care where the digital tool enables the communication and the decision-making across the healthcare team. At the University of Melbourne, we really have a multidisciplinary team that we're putting together that addresses all of the different issues that are important for implementing innovation in healthcare.
On one side, we have university and traditional researchers generating a lot of innovation in the use of artificial intelligence and digital technologies, human-computer interaction.
We're also really fortunately situated here in a world-leading hospital precinct. I think the mission of the centre is to work together with the health economy to both figure out new ways to solve problems in digital health, but also then actually do it for real.
The Validitron provides an opportunity for companies to implement what they're doing into the healthcare market.
We want to be able to meet innovators where they're at in their product development journey and really help them figure out what are the priorities to address.
There are two key components in the Validitron that support this process. One of them is a digital sandbox.
We have all the digital components that would normally be part of the healthcare system. So an electronic health record for general practice, a simulated electronic health record for a hospital environment, a telehealth client, smartphone applications, secure messaging systems, and so on.
But the IT part and the data part are really the enablers for the workflow. And so we also have a simulation lab, which is a physical space with a GP office, a hospital room, and a patient home.
Which is designed to be really immersive and really bridge the gap between what you can do in a lab and what you can do out there in the real world. As innovators come out of it, they're able to go to funders or to healthcare providers and say, I have a product that is well validated.
We bring a lot of expertise.
Okay, so that just gives you a little brief introduction to the Validitron. And so I'm just going to finish by saying a little bit about a second project. So this work is based on the idea of identifying evidence of suicidal ideation and self-harm from emergency department clinical notes. Okay. And this is a local example of medical AI. In this case, applying NLP to do public health surveillance to identify trends in self-harm. And self-harm is a major issue in Australia. So for every death by suicide, over 300 people are hospitalised for self-harm. In Australia, so it's a major problem here, and it's and so developing rapid interventions and just understanding changes in the community is very, very important. So why do we need to do NLP for this task? Why can't we just use coded data? So the ICD codes are typically not suitable for identifying instances of self-harm, and this is because oftentimes the ICD codes are added later, so they're not timely, and also they just don't often capture self-harm. So the particular self-harm code isn't used. So if we want to identify evidence of self-harm in real time, that information has to come from the note. So for this project, the researchers used 300,000 notes derived from the Royal Melbourne Hospital. And each note is labelled as positive or negative for self-harm as a sort of routine administrative task retrospectively. But the really tricky thing about this task is that only 1.4% of notes are positive for self-harm. So it's quite rare. And as we all know, it's challenging to identify positive instances with these kind of rare events. Additionally, the data is quite hard to work with as well. So it's typically short texts. The grammar it can be eccentric. There are spelling mistakes, very specific terminology and abbreviations and slang and so on. So you can't just use an existing model on this data because it won't work very well. But this is a really interesting example because it's quite a hard problem identifying self-harm because it's, as I mentioned, it's quite rare, and also the data is as I mentioned, is quite eccentric. But using classical machine learning based methods, it's actually possible to get pretty good and useful results for this task. So, for example, here the researchers achieved a precision recall of about 0.8, which is good enough to be useful for this particular task. Which is health surveillance. So that's two examples of projects here at the University of Melbourne. So I hope that's given you some insight into the kinds of things that we're doing here in Australia and specifically at the University of Melbourne. So thank you very much for your attention. It's been my pleasure to talk to you today. Thank you.